In contrast media, as you all know that contrast media administration and all is taken care by a medical officer or a medical technologist or a radiographer, whatever you call whoever you call them. So there are some considerations when approaching a patient, which I'm sure everybody knows, but let me just refresh it. To ensure the administration of contrast is appropriate for the patient for the indication, to balance the likelihood of an adverse event with the benefit of the examination, to promote efficient and accurate diagnosis and treatment, to be prepared to treat a reaction if it occurs. So these are some of the considerations that a medical officer should be aware of. And achieving all this depends on obtaining an appropriate and adequate history of each patient. This is something very important, that the history of the patient should be always, recorded by this thing, by a medical officer or medical technologist. And then considering the risk and benefit of using or avoiding contrast also is one important, is something important. And then preparing the patient for the examination also lies with the medical officer. Having equipment available to treat reactions and competency also lies with, is the responsibility of medical officer. And ensuring that personnel with sufficient expertise are available to treat severe reactions. I mean, if the medical officer is expertise in this, okay. Otherwise, there should be somebody. I mean, who is expert in this, that should be nearby. Supposing if it's a lab, then there should be somebody. If it's a hospital setup, then maybe there are other departments. Next slide. This thing. Okay. Now, the main responsibility of a medical officer for contrast admin is aseptic technique competency, basic life support competency, and he or she should refer to the product package insert for doses and risks, because whatever the product is, he should know the doses and what are the risks and all included with that. And then to ensure that the risk factors are identified and managed through the history, to ensure that the patient is informed of the risk associated with the procedure, that he has to, speak with the patient. Next slide. Okay. There are some risk factors associated with IV contrast. Generally, contrast media, should be given when the benefit of using a contrast is much more than the risk to the patients. Okay. So now, let us say previous reaction to contrast media and allergies. Maybe you can consider, pre-medication, or consider, different modalities if the patient is not this thing helpful. And then for asthma, ionic should not be used. Only non-ionic contrast should be used. And if the patient is highly severe kind of asthma patient has, then pre-medication with corticosteroids is recommended. Allergies, as I told you, pre-medications with antihistamine or anything should, if possible, should be used. Or else, if it is not sufficient, if the patient still has allergies, if you're using iohexol like Contrapac, then maybe you can shift to iopamidol and see. That also can be, tried. Then contrast current medication. As I told you, medications, should, when a patient is using medication, you should always decide to use a contrast media if the benefit of using a contrast is more than the risk. So, let us say now diabetes. Generally, if a person has diabetes, then they are advised to stop medication 24 to 48 hours before and after the contrast admin. administration. Thyroid, yeah, because thyroid, this contrast media, CT contrast, it introduces large amount of iodine in the body. So the thyroid function all should be monitored for at least for 24 hours for high risk patient after administering contrast. Next. Then myasthenia gravis and all, yeah, generally considered safe, but patient has to be monitored at least for 24 hours. Then sickle cell and phaeochromocytoma, yeah, can be administered safely. Uh, non Ionic should not be used. Ionic should be avoided. Generally, non-ionic low osmolar contrast is preferred. Pregnancy only if it is much essential, then only it is recommended. Gadolinium is not recommended because it crosses the placenta, and IV contrast generally, iodine contrast generally has not been shown to have any significant risk to the fetus, but because the increased radiation, it could impact the thyroid function of the fetus. So mostly during pregnancy, if the other modalities cannot be used, then only this should be used. It all depends on the physician. Now, cardiac state is also an important consideration. Patients with significant cardiac disease seem to be at risk of reactions, yes. Emotional state of patient also plays a very important role because if the patient has anxiety and all, the patient will not be stable. So until unless the patient is stable, you cannot get a good, image and all. Then renal disease, as you know, renal disease, the blood urea, nitrogen, creatinine, they all should be considered before. So paraproteinemias, multiple myeloma, because the blood viscosity increases. So interpretation and clinical awareness should be ensured for accurate diagnosis. And age independent from general health of if the patient is healthy, then it is not a major consideration in patient preparation. And in infants and neonates, contrast volume is important because they have low blood volume. Next slide. Now, the basic requirement during contrast administration. Okay. Uh, Generally, in a hospital and all, you'll find all these things, but in a lab, in a diagnostic and all, you should, always have all these, available readily, just in case. So, like defibrillator, oxygen mask, suction equipment, oral nasal airways, IV sodium chloride, IV cannulas, adrenaline for anaphylactic shocks, salbutamol for inhalation, loratadine for allergies and all, hydrocortisone for inflammation, allergic reaction, ondansetron for nausea, vomiting, glucagon for hypoglycemia, atropine for bradycardia and all, glyceryl trinitrate to increase blood supply and chest pain. And of course, cardiac monitor, pulse oximeter, all this, non-invasive BP, invasive monitoring, pressure monitoring, and all should be available. Next slide. Now we come to the considerations for injection of contrast media. Contrast media injection methods vary depending on vascular access, differential diagnostics, and imaging examination type. The mode and method of delivery, either by hand or power injector, also vary by procedure. Generally, if you're not able to find the vein or veins are small, then yeah, you can give it by hand, but otherwise, power injector is preferred. Bolus, bolus of power injection of IV contrast is superior to drip, yeah, of course, because uniformity is there if you give bolus. Standard procedure should be used to clear the syringe and pressure tubing always. Always for every patient, the tubing should be changed. The syringe should be reoriented with tubing directed downwards, yes. All maneuvers can be performed by the technologist to confirm the proper intravenous location of the catheter. Next slide. Okay, now again the same thing. The catheter to be used should be checked for backflow of blood into the tubing. That is, general thumb rule. Catheter should be clean and all. Patient should be asked for history of diabetes, hypertension, renal condition, chemo, and underlying conditions, if any. Yes. Saline, always test flush should be performed by hand or once the tubing is connected to a power injector. To avoid complications, the patient's cooperation should always be obtained whenever possible, because if the patient is calm, things will be smooth. Careful preparation of the power injection apparatus is essential to minimize the risk of contrast media extravasation or air embolism. Air embolism and extravasation should be, always avoided. That will come to later part. Communication with the patient also plays a very, important role. Because as I told you, the calmness of patient, the movement of patient, if the patient is having, some kind of anxiety and all will, always, always, give some this thing or the other, or like extravasation or those kind of things. Now we come to extravasation and air embolism. Extravasation and severe extravasation injuries are more common in patients who are not communicative, have altered circulations in the injection extremity, have had a radiation of the injected extremity, or are injected in the hand, foot, or the ankle. Extravasations are also more common in patients injected with more viscous contrast material. Yeah. The risk of extravasation can be minimized by using angiocatheters rather than butterfly needle, because angiocatheters have long needles. Performing meticulous intravenous catheter insertion techniques, and then carefully securing an inserted catheter. Next slide. If extravasation occurs, then generally elevate the limb, apply cold or warm press, monitor for compartment syndrome. And then next, air embolism. If clinically, significant large volume air embolism is potentially fatal, but rare complication of it. Very rare in IV contrast media injection. Small volume clinically insignificant venous air embolism commonly occurs, but it is visible, so it can be taken care of. Using care when using power injection for contrast and CT minimizes the risk of clinically significant air embolism. Okay. On CT, venous air embolism is more commonly identified as air bubbles or air fluid levels in the intrathoracic veins, mainly pulmonary artery or RV, although it can conceivably be visualized in any vessel downstream of the injection. Okay, now we come to the flow rate and cannulation. For IV contrast administration, we ensure that large veins are used, preferably cubital fossa, antecubital fossa, large veins. Back of hands and foot and all should be avoided because of extravasation can happen. Ensure that all cannulas are flushed and patent priority injection. Yeah, it should be clean and all. No particles should be seen. In the absence of a suitable peripheral IV cannula, power injectable lines can be used to administer IV contrast media. Power injectable lines can be used in the absence of any cannulas, yes. Then ensure that the flow rate should be appropriate for the gauge of the catheter used. So if 22 gauge or larger is used, then the flow rate should be 3 ml per second. If 20 gauge or large is used, then the flow rate should be 5 ml per second. If 18 gauge or large is used, then flow rate should be around 6 to 7 ml per second. If hand or wrist venipuncture site must be used, then flow rate should be reduced. That is around 1 to 2 ml per second. Okay. Okay. Now we come to the storage and handling of contrast. Like contrast media, viscosity plays a major role in the storage of contrast media because it is related to temperature. The colder the temperature, the more the viscosity. So contrast media viscosity, like that of many other liquids, is related to temperature. As the temperature of a given contrast increases, there is a decrease in dynamic viscosity. So iodinated contrast should be stored at room temperature away from direct light. Prior to use, IV contrast media should be stored in a warmer and kept between 30 and 37 degrees. Like if warmer is present, it is well and good. If no, then a normal room temperature is okay. No need of keeping it any AC room or in the gantry or any other place. Not even the AC. The iodinated contrast media should to be dated with date placed in the warmer, stored in the warmer, storing in the warmer reduces the viscosity of the media and injection pressures. When a warm contrast medium is hand or power injected into an IV or IA catheter, there will be less resistance. If the contrast is a little warm, then resistance will be less because of the viscosity. IV iodinated contrast media should be prepared using a non-touch aseptic technique. Yeah. Once opened, any unused iodinated contrast media should be discarded within 24 hours. So it shouldn't be used for more than 24 hours if it is opened or if it is present in the pressure injector. Once the contrast file is open, the batch number and expiry date from each contrast bottle should be documented as per whatever your hospital or your diagnostic center's policy. It should be documented. Next slide. So now we come to the summary, standard guidelines. This is before administration of contrast. Identify, this is the role of the medical officer. Identify if patient has allergies, previous reaction, diabetes, and renal impairment. Patients with known contrast reaction to be given medication instructions at the time of scheduling. Meticulous IV technique is required with contrast media, particularly during angiographic procedures to minimize thromboembolic events. Patient should be well hydrated before and after admin of the contrast. Expiry date of contrast and body temperature should be checked of the bottles if it is cold or not. Contrast should be drawn with non-touch aseptic technique. Just visually confirm that there is no air present in the syringe and extension tubing. Clean hands, don non-sterile gloves. Confirm if cannula size is ideal for protocol procedure. Check the expiry date of saline also. Confirm patency of IV cannula by flushing a labeled 0.9% sodium fluoride at a rate similar to the contrast injection through the other pressure injector. Connect power injector extension tubing to patient's IV cannula using non-touch aseptic technique. During the procedure, observe the power injector monitor and patients at the time of injection. Recognize potential complications and correctly identify identify appropriate intervention. That is, I mean, if extravasation, allergic reaction, high pressure readings and all should be monitored. Post procedure, check on the welfare of the patients. Clean hands, don non-sterile gloves. Check expiry date, flush the IV cannula with sodium chloride immediately after medication administration. Dispose of equipment in appropriate manner. Document contrast batch number and expiry as per your procedure protocols. Thank you.